All right. Well, we are back with another PCBH Corner. I could not be more excited to have straight from the horse's mouth a family physician, a primary care physician who works in the trenches, does the daily work. And we have with us Dr. Jen Thomas. Now, in addition to her doing the work, she also is an integrated care leader in her organization and has also been joining more and more national organizations regarding things related to integrated care, and is on the Collaborative Family Healthcare Association's Integrated Care podcast. And so we have two main objectives for today. One is trying to find out from Jen, Dr. Thomas, what she might want BHCs to know about her experience as a provider and how essentially integrated care and behavioral health providers, BHCs, how could they help Jen? Or, you know, if they're not working directly with Jen, somebody very similar in a similar role. So basically, yeah, how can BHCs, like, how can you help Jen? Like, what does she need support with as a primary care physician? And then we're also going to talk about, from Dr. Thomas's perspective, what does she want physicians out there to know? Not only the physicians that are in the trenches doing the everyday work, but also folks that are in charge of work groups and different national initiatives that are trying to make integrated care go from something that's novel to something that's, you know, kind of a household term. So.
All right. Yes, let's do it. I'm excited. Yeah, cool. Thank you so much for inviting me, Bridget. This is such an honor to join the PCBH Corner. Yeah, I mean, I guess I'd kick it off with just organically how our topic came up. I would just really like to envision a future where primary care, behavioral health, integrated care was just how we do medicine, right? It's just baked into, we learned it in med school and residency. We do it in practice when we're off in the real world with our real job, and it's just part of the culture. So I guess just excited to spread the word and awareness that this could be a culture transformation where it's not the new hot thing, it's just the what everyone does, it's the future. So I'll just share my experience. I didn't know what I didn't know about integrated care. I mean, I stumbled into learning about the COCM model as a PCP for years. I felt this pull of like, there's certain things in behavioral health that is outside my comfort zone, just a little bit outside my reach, right? In formal training, you know, in family medicine, we get some behavioral health, but I mean, not enough. Like you leave the formal training and you're like, man, that's it. I'm on my own. I'm a real doctor. I have to make diagnoses. And especially in family medicine, you know, you get so much behavioral health conditions coming through the door. And I think most PCPs feel pretty comfortable with, you know, depression, anxiety, but sometimes you know, there's other context out there. We didn't get a lot of formal training on, you know, trauma, PTSD diagnosis, mood disorders, where we know of those conditions, but maybe we're not as comfortable making that diagnosis. And it's very diagnosis driven in the medical world, right? We have to chart and pick an ICD-10 and pick a diagnosis. So there's sometimes where we're a little hesitant to label someone. I mean, sometimes you talk amongst your peers like, well, is that condition, is that label going to follow them? Is that going to make it tough for them to apply for short-term disability? You know, like all those things come into mind and they're, well, I want to be really sure. I want to make sure I'm being accurate in my diagnosis. And so that's where I just feel like, you know, that's what could really help me in my day-to-day busy primary care schedule, is just having another teammate to bounce things off of, run things by, like, hey, I'm thinking ADHD. How can I make sure that we're on the right track? But, you know, we definitely got some anxiety and trauma stuff. So BHC, can you help me kind of tease that out? Because I'm 40 minutes behind, you know?
You just made two really good points, is that having that teammate, somebody you could bounce the ideas off of, and then somebody to kind of help with the and I use the word burden, not that patients are burdensome, but the system. And, you know, having to see, I mean, in an average day, how many patients are you aiming to see?
Yeah, I mean,
all day?
Yeah, a busy PCP might see, 10, 15 and a half day, I'm a little bit less. I do more admin stuff in my role. But when I first started the trenches, yeah, like you got sometimes 15 minutes and you might double book on top of that with acute sick visits. So it's very fast paced for sure.
That's basically it's 20 to 30 patients in a day for a PCP. And then you're trying to really be conscientious and mindful of all the different considerations to do best by your patients.
Yep.
And kind of managing that all alone. And what you're saying to me is that with a behavioral health teammate, you have somebody else's eyes on it, somebody else's expertise on it.
Yes.
And it's just helping with, the everyday functioning, because if you are 40 minutes behind and then you have to handle that all on your own, what kind of care are you going to be able to bring to that next patient?
Yes, exactly. And that it really takes a toll. Like it does contribute to your sense of burnout. You leave work at the end of the day with that, I left it all out on the field. I'm done. I'm exhausted. I've got 2 hours of charts and now it's time to transition to my home life and I'm beyond empty on the tank, So yeah, I think, working on a team, absolutely. It can help just provider wellness and just us feeling like we have a sense that we're truly helping our patients and doing right by them. So absolutely, I think the team-based thing, we can't get enough of that. I think we need to just clone those BHCs and get them out to everyone if we could.
Yeah, that's you got me hyped right now. And we know that there's a shortage of providers, especially, physicians going into family medicine for myriad reasons.
Yeah.
A lot of it that is related to funding and do I even want to open up that box right now? But to be able to create a context that's more sustainable for physicians is absolutely something, if you're an effective BHC, that you can contribute to.
Yeah, absolutely. And I think primary care, I guess I didn't even realize when you're training, it's like, yeah, there's a lot of behavioral health in primary care. I don't think you really internalize and own that, philosophy or that overarching statement until you're out in the trenches. You read those stats like, well, primary care is the de facto mental health provider. We write 70% of the antidepressant prescriptions in this country, not specialty mental health, not psychiatry. And it's like, whoa, that's a lot of mental health. And that's great. And it's whole person care. We want to be doing that. But man, we just maybe need a little more support, a little more training and comfort so that those conditions are, we feel competent, right? Because I think if we feel scared or unsure, and then we kind of shy away. And I would like to see us do the opposite and lean into those conversations.
Right. I mean, we say all the time, like, it'd be like expecting somebody going all the way through grad school to be a psychologist, and then having a few lectures, a few rotations with diabetes management, and then making complex decisions about metformin or the diabetes medication. It's like, we wouldn't feel, a psychologist wouldn't feel comfortable doing that. So we have to start making some changes including better training in medical school and residency, and then having the teammates. So I mean, this is coming from lots of different angles. So I'm curious, like, as a physician, when you're going through your day and imagining back when you kind of, like you said, for the earlier years when you were doing clinic multiple days a week, and you're thinking to yourself, like, man, what would I want my teammate to help me with? Like, what would, like if you can create your ideal state with regards to behavioral health integration, like, not even talking models, not even talking whatever, just like, what kind of behaviors would you want to see out of a teammate or teammates when you're doing your clinical work?
Yeah. The biggest thing that comes to mind is just an extension that helps you get to know the patient in their context, because you feel a pull to get in there and really understand their living environment and their past traumas. But man, in primary care, it's like you're always watching the clock. I gotta go. I just got 5 more refills. I'm 40 minutes behind. So I think if we could ask our behavioral health teammates to be an extension of us and spend that time sitting down, learning context, boiling it down to 30-second minute spiel of, hey, Dr. So-and-so, this is the context. So this is why that behavior, these symptoms make sense for this person. They have, an incredible amount of grief and trauma they're processing. And PCP goes, gosh, I didn't even know that. That makes sense. Now I feel like I've got some footing to help, identify, how we can help them with their symptoms or maybe work on their goals. But I guess time. I mean, as I'm just thinking, I'm like, time. I think it's time. I wish we just had a little more time to sit with folks. So if a teammate could help us, right, dig in, wouldn't that be cool?
Yeah. Oh my
Yeah.
God, I love that. And if, and not putting anybody in the spot, because like we don't want to think through like maybe difficult experiences that you've had with integrated care or
Sure.
really positive. So we're not going to name anything. We're not going to name anything. Just thinking along the lines of like, if you had a team, like, if your teammate was there and showing up, you would want them to be able to work as an extension of you, to be able to go and get contextual information to help you get to know your patient, boil it down, communicate well. Anything else that's coming to your mind for it's like, gosh, if I could like, build a robot, but of a living, breathing human being, but like what qualities would I put into that?
Yeah. I mean, I think in primary care, most providers would agree that sometimes there's certain diagnoses that we're like, like, well, does this person have ADHD? They came in asking for a stimulant, or this person says, hey, I think I might have, my wife thinks I have bipolar because I'm moody and I yell and throw things. And you're like, so you walk that line of like, okay, I want to, really listen to what your concerns are, but maybe having a conversation of ruling out things could also be helpful for PCP. So, again, not to say that we have to, do a diagnostic eval on everyone, but just kind of back us up with like, I really don't think this person has bipolar disorder. I think they're describing some mood swings that probably have more to do with their stress and their environment. Can you help me kind of communicate that to someone in a way that doesn't sound off-putting? Because, I think in primary care, sometimes we're so fast, right? It's like, no, you don't have bipolar. Can I refill your hypertension med? Okay, bye. And it's like, patients don't want that, right? They want to be validated. They're like, but I just said I have a really troubling mood swings. How can you help me with that? If it's not bipolar, what the hell do I do? Right? How can I help?
Right. Man. Oh, I absolutely love what you're pointing out. And just it sounds like the willingness of a BHC, like we were talking about before we started the recording, which I'm like, man, we probably should have just hit that recording from the beginning. But to be a BHC who can go in and just help you. Like, so if it's whether it's differential diagnostics or if it's a situation where it's like, we actually think it's this, like you said, well, no, what the hell are we going to do about it? And even if you, as the physician, had some ideas for what to do about it, there might be situations where you literally don't have time,
right?
Or, you haven't had as much extensive training in like communication. Okay, well then how should I communicate this? So just like all of the above, basically being willing to jump in and.
Yeah, absolutely. And that's such a cool concept. I think that if most PCPs, ones that maybe are new learners to integrated care, had that conceptualization of there is a world, there is a concept, a model, whatever, where you've got a behavioral health generalist that could work right alongside you. They're the other clinician in your primary care office that can be, seeing patients all day, jumping in to do a warm handoff. If we get in the weeds with someone, like, I'm not really sure, I could use a little backup here. That's awesome. And I fundamentally believe that there isn't a PCP out there that'd be like, nah, I don't need that. I think they'd all be like, sign me up. Get me too.
Well, that, Jen, is a fantastic segue kind of into our second thing about, what do we want PCPs to know? What you just said, for the record, is absolutely beautiful. And so, thoughts, ideas on how to make this more a household, just like this is, everybody knows about going to the pediatrician or having a family doc. Everybody knows that. Like how to make it's like, well, when people think about, I have my family doc, I got my family BHC. Like, how do we make this happen? Or what would you want if a physician is watching this? Like, what do you want them to do?
Yeah, I mean, I guess it starts at home in your home health system. And that being said, I would also then nudge people to get involved and find the like-minded folks in professional societies, CFHA, AMA, med psych societies, those kind of groups, because then you find your folks that are also passionate about it, and you'll get into the weeds and you'll need to phone a friend and like, oh, we were trying this and we're getting stuck. What do I do? And this program drift happens and now my BHC is like all scheduled and it's not supposed to be like that, because that's going to happen. It's going to get messy. So I think any community you can build to get friends, colleagues, folks that are a little further in the journey, like, yeah, we did that and here's how we got back on track. Oh my God, you're going to need that. You're going to need cheerleaders. You're going to need friends on the journey. But starting at home, your health system, I think PCPs have to pick up the sword or the whatever and be a leader for integration. I fundamentally believe that, because we have to change the system from the inside out, because the healthcare system has a lot of flaws. It's broken in a lot of ways. And I think our, medical providers, physicians have a lot of sway in saying, we need to change the system. We got to have billing mechanisms to make this work fundamentally sustainable from a financial standpoint. We need to just spread awareness and education that this type of stuff is out there. So I guess I would say, if this speaks to you, get ready to put on a pad and helmets, because being an integrated care, advocating your health system, it ain't easy. It's bumpy. You have to kind of ruffle some feathers and say, yeah, I know I always did it this way, but maybe we've got to come at it from this way, because the old way ain't working, right? This whole siloed, here's a referral, good luck finding a provider that will take your insurance and see you in 3 months for an intake. That's not getting it done, So I think that, this work is important, but we got to kind of shake things up a little bit and have some friends along the way for when it gets bumpy.
I love that. And you get this when folks are out in the real world doing this, about mentioning, and I'm going to channel my inner Dr. Bauman right now, about like how great it is to be real about this stuff. So, Dave and I have this joke about if somebody says, okay, with regards to integrated care, whatever the model, whatever the approach, you just need to do these 3 things. It's like, I'm not saying those 3 things aren't important. I'm not saying those 3 things haven't been studied. I'm not saying I don't do those 3 things and utilize them on the daily.
Sure.
But if you just say, you got to do these 3 things, and then in practice, knowing how messy it is, there could be that disillusionment. So I guess that's something that I'm hearing from our conversation, that you want any PCP who's going to kind of take the bull by the horns to know this is going to be a bumpy ride, and you might get thrown off that bull a few times as well. I think it's important for us to acknowledge.
Absolutely. And by the way, if you're trying to juggle full clinical load, good luck, right? And you're going to have to advocate for some time or some FTE. I mean, you're going to drive yourself nuts trying to make that your nerdy hobby on nights and weekends to build integration. I've been there. It's fun. I mean, you gotta, if you don't burn out, right? If you don't carve out time, then you're not taking good care of your integrated care program or your existing patients. But and that's an uphill battle conversation where you have to advocate for the leadership, the value of leadership, right? Because as a PCP, what's your value? Your high productivity, RVUs, revenue generator. But if you're also leading integration, then that's a different value, and it's just a different conversation. So again, get some smart friends, CFHA folks. I can't tell you how life-changingly important those connections have been, just to talk through this is what I'm hearing, this is what I'm seeing. I'd like to lean in more to leadership. Can I do that? How do I do that? Finding those mentors is beyond priceless, for sure.
What keeps you going with regards to kind of being an integrated care champion as a physician, and like you said, joining different committees? I like splice meetings and committees, different initiatives through all the bumps. Like what keeps you saying, you know what, this is, I have to do this, even if this is uncomfortable, even if this is attempting to buck the system. And in some ways, you may have had an easier route to just put your head down and not say anything.
Yeah. I mean, gosh, my personal motivations, I think it's 2-part. It's personal, it's professional, right? Like most things where, personal life, it's like, I have lived experience being a family member of someone with severe persistent mental illness. My younger brother, Josh, has schizoaffective disorder. So I've been in those situations where he doesn't get access to care because of insurance or his meds aren't working. And, I think that puts a fundamental core belief in you of that behavioral health is health. It's a right. It shouldn't be something that is a social determinant, that if you're poor, you can't get access to care. I think that's not my belief system. And I think that shows in my practice. So I think that's part of who I am and why I'm passionate about the things I'm passionate about. Yeah, I mean, and again, personal, my family, we've been through some heartache. We lost my dad to suicide in 2013, and in primary care, those types of conversations come up all the time with treating depression, right? Screen for suicidality. Do you have intent and plan to harm yourself? And again, lived experience gives you a kernel of empathy, that not that you can't empathize with someone if you haven't walked that path, but when you have, and you have seen the effects of mental health on you personally, I think it does and can, in a good way, grow professionally a passion to help get people access that are suffering, help change the system a bit so it's not so hard to get care and get well. So yeah, I think that's kind of my personal background. And then professionally, it's primary care. It's all day, every day, right? It's part of human health, right? We're living, breathing behavioral health stuff every day when we treat someone in primary care, because it's head to toe. So I think over time, as you exist in that system where you say, ooh, the system isn't great for me knowing as a PCP what the therapist or the psychiatrist does, because care is so siloed. You go, well, that's silly, right? I get a cardiology consult note all day long, but I never get a psychiatry note. What's that about? Because I'm writing meds and so are they. Like, that's silly. Like, we need to change that. So again, I think it's kind of the what drives me on. My motivation is sort of that, yeah, the day-to-day professional work, baked in a little bit of the personal life. And I think it just comes together to make a, behavioral health integrated care geek like me, who's like, "Raw, let's do this."
So you're deeply rooted in your values, and quite frankly and simply, it makes sense to do when you're looking at the whole health. It just makes sense to have it live in primary care as the place to be.
Absolutely. And it's accessible, right? I mean, that people see their primary care provider so much more. Well, I think you shared that stat, right? Like, we get to touch 80% of the population in specialty health. A lot of people don't make it there. There's barriers, and it's like, that's not good enough. They still come into our office in our little community, so we gotta help. It's all hands on deck. We can't just go, well, you didn't make it to psychiatry. Let's talk about your ankle and your back, right? It's part of the whole thing.
Right. I know one of the things that, and I just want to thank you for just being so open and so vulnerable. I think that, sharing these absolutely heartbreaking lived experiences, I got chills, when you're talking, is important, because that's what we're talking about people's lives here. And as any of us going into healthcare, whether you're a physician, a PA, NP, psychologist, counselor, LMFT, and so forth, like, you came in here to help people, and like that's what we're talking about here. And so you and I were talking about before the recording as well, about almost kind of like what you would want a physician to know about integrated care. And I think using the perspective of, like, when you first started out, like you said, you hadn't even heard, like, as a PCP, right? Like, you hadn't really had, was it no exposure to integrated care, or having like a behavioral teammate, or like a little bit of an exposure?
Yeah, I mean, in residency, we had a co-located, I think he was an LMFT that did some counseling, so a bit of a co-location. It wasn't a big part of our practice. It was sort of he's over here and does his own thing. And that was really the extent of my formal training that had any flavor of integration. So yeah, no, I mean, I guess really I didn't get any. I mean, honestly, my first exposure to integrated care, I took a primary care psychiatry fellowship in 2018 through UC Davis. Awesome experience, med psych doctors, like, really coaching up PCPs on doing more with psychiatry and behavioral health. And I heard of the COCM model. I was like, oh, that could help. That strikes the, I like the idea of having a BHC or BHCM in my office. Let's do that. Let's try that approach. So yeah, it was literally just dumb luck of like going to conferences and hearing about programs. And I know that, a lot of people get exposure that way. And I think that's great. But like, you don't want it to be I stumble. It shouldn't be like, oh, you struck gold. It's like, no, you were taught gold and you raised on gold. You don't know anything else,
That's so absolutely Well,
right?
so you would want it just to be, talked about from the very beginning, that
Yep.
as you're a physician going through, you
Yep.
get exposure and say, okay, all these different flavors of integrated care. Here's
Yeah.
what you could expect out in practice. And then when you actually went out to practice, there actually was that.
Yes, you actually had that. It
We
wasn't
actually
just
had that.
the,
Yeah,
the mountaintop ideal. Exactly.
My goodness, we have a long way to go, but
We do.
we're more likely to get there
Yeah.
with folks like you who are talking, speaking on this topic. And yeah, I mean, if you have a physician who took the time to listen to whatever minute we're on in this PCBH corner, is there anything else that you just would want to let them know about with integrated care, or how they can get started to learn
Yeah.
more? Or
Yeah. I mean, I would always say, don't be shy. I think in early in practice, I had a bunch of little kids and I was just kind of like surviving the day-to-day like crisis mode of like diapers and sleep deprivation. And now they're a little bit older. I'm kind of like, okay, take a breath. Not that we're not busy, but like, look around, reach out there, knowing about CFHA, the AMA's behavioral health collaborative, there's immersion programs, there's all sorts of modules. There's material out there. And I think the PCPs are hungry for that. I know they are, but just get curious, turn on a podcast, look up of a webinar, and you might find that it speaks to you in a way that can be really exciting to, I think, kind of help respark the why, right? Because that whole remedy for burnout. Why do we get disillusioned and like, oh, I don't care as much. It's just same crap, different day with patients. It's like, I don't know, for me, integration has been a resiliency factor of like, oh, this makes me enjoy coming to work. It's nice to have a colleague to talk with and learn from and teach them some stuff. That's cool. Like, that's why we got into this in the first place. So I don't know. I think, yeah, get curious, learn, reach out, Google, shoot. I mean, anything you can learn about integrated care, I bet you won't be disappointed. I think you'll be really pleasantly surprised.
And your lived experience again shows that difference of like practicing in a silo versus now that you have a team practicing. And it seems like it's almost like once you have that, it's almost like you can't go back.
Absolutely. Absolutely. That's kind of what the vibe is in my health system. The PCPs got a taste for integrated care, and they literally have said, like, we're not going back. Like, we don't want to practice in a way where we don't have a BHCM in the OB office, because our patients need her so much. It's so nice to have input on their medications and such. So yes, I think creating those champions, that's going to help keep the momentum going, is that just, folks know about it. They like it. It helps them. It helps their patient. It's a win-win.
Well, I just want to say, Jen, that I think I said before we even did the recording that I was like, man, I just want raw, straight from the horse's mouth, Dr. Jen Thomas, like your lived experience. And it did not disappoint. I didn't even know that it was, I mean, I knew it was going to be good. I knew it was good. But I don't know, this was really good. I have really just had an absolute blast asking these questions. So we'll pose the last question as we look towards wrapping up. Is there anything that we haven't talked about this morning that is just kind of really burning on your mind or in your heart that you want to make sure that we promote, that we talked about, that we said?
Yeah. I guess I would just say, again, get out there, get curious. I can't speak high enough about CFHA. Jump on a work group call, just listen in. I think if you're a PCP that knows a little or a lot or none about integration, tuning in and listening to a work group or a webinar, it's a fantastic place to start, and just want to make sure that that's out there for folks, because it's tough feeling isolated and alone sometimes in anything we do, especially in the work environment post-pandemic, that it's tough. So you're not alone. There's people out there that are cheering you on. So get out there and make some friends, and you probably find you're a lot happier and healthier because of it.
Oh my. Well, that just seems like a beautiful, beautiful place to stop. And so all the gratitude in the world, Jen, for joining. I don't even know when it came to me that I was just like, oh my gosh, like we have to do
this.
PCBH Corner. Of course, you're like, okay.
Woo.
We had a few notes and that was it. you know, and so
Yeah.
I don't know, just all the gratitude your way. And I
Same here.
appreciate
Same.
and covet your lived experience as a physician
Thank
and as a
you.
person.
Yeah, it's, hey, that's our journey, right? We all have our stories and we can, you know, do with that what we do. So, you know, make it your own and day by day, right? Live your values. So thank you so much, Bridget. This was a blast.
Awesome. All right. Thanks, y'all. Thanks for watching. I hope you made it to the end here because I think it's well worth your time.